Good morning. Today I'm going to go over Module 1, PowerPoint 2, which is going to cover chapters 6 and 7. So the first thing I want to do is go over chapter 4's quiz, which you took last week. All right, so the first question was a common and physical change related to pregnancy, and they're looking for common. All right. So severe headaches, frequency and urgency to void, abdominal or pelvic pain, or frequent urinary tract infections. So what would be common? And hopefully you said frequency and urgency to void. Be careful about abdominal or pelvic pain. They should not have abdominal or pelvic pain. That could be a life-threatening maternal high-risk complication known as placenta previa. During the prenatal period, a woman is instructed to take folic acid. Folic acid decreases the risk of A, preterm labor, B, neural tube defects, C, twins, or D, gestational diabetes. And you should have put neural tube defects. A patient arrives at a maternal health clinic. Which sign is a positive sign of pregnancy? Positive sign is sonographic visualization of the fetus, positive pregnancy test, nausea and vomiting for 2 weeks, absence of menstruation. So you should have sonographic visualization of the fetus. The client is coming to the clinic for her first prenatal visit. She should expect the healthcare provider to A, assess daily fetal kick counts, B, perform a Leopold's maneuver to identify position of the fetus, screen for gestational diabetes, or complete a comprehensive history and physical assessment. So you should have picked the last one. A nurse is assessing a newly pregnant client for intimate partner violence. What should the nurse not do during the assessment? And I think a couple of students didn't catch the not. So be careful. Make sure you're reading your question completely. So what should they not do? With the client's permission, document with photographs and verbatim account. They should do that. Ask the spouse or significant other to step out of the room to perform an exam prior to asking. Reassure the woman that she is not alone and help is available. Allow the spouse or significant other to stay during the assessment. So she should not allow the spouse or significant other to stay during the assessment. All right, so that was your quiz. All right, I have a bunch of housekeeping information I want to go over with you guys. There's so much information I need to give you, so please take notes, go back, listen, ask questions, put it on the Q&A, which I do have to go and take a look at today. Clinical assignments. I got a lot of emails about clinical assignments. I put all the drop boxes in. Initially for Saturday, I didn't put no more than 2 drop boxes because the Saturday group initially was only going to have virtual one Saturday and one Monday. Well, that didn't happen because of having to postpone clinical. So I went in and put all the drop boxes in. If you, and this is going to be for my PM group first, I'll start with you guys. PM, if you have a pediatric assignment, so in other words, on the clinical schedule, say next Monday, I believe next Monday or last Monday, like February 1st, yesterday, everyone did PIT. So no one was in doing OB. So I would not be looking for an assignment. Say the following Monday, February 8th, half of you are doing an OB assignment. The other half are doing a pediatric assignment. The students that are doing a pediatric assignment, I am not looking for your assignments in Canvas. I know the schedule. I know what students are where. The clinical instructors know what students are where. So please don't worry. You're not expected to do double work, in other words. So I did get a lot of that. So just to clarify, PM students, I'm only looking for work in the drop boxes when you're doing virtual ATI with your clinical instructor for OB. Okay. Recorded lectures. This has been an uncanny year in every way, shape, and form. I don't know how much snow that you guys have, but I am pushing a good 2.5 feet of snow right now. So literally just trying to get out of my house, and we do have animals, and so just trying to get out and feed those animals and stuff is a chore in itself. So I do understand that a lot of you are visual learners and or need reinforcement. So please use my office hours. I have if you have a couple of students, you like study partners, you're working together, by all means, reach out and if you have some questions as you're studying, because I know some of you do create study partners and work together, please reach out to me and we can schedule something for like a little mini group session if you have certain questions about content. But just send me an email about that. Okay, here is what I really need you guys to listen to. All right. So as I'm planning on getting everyone fit tested who needs to be fit tested, this is the information now. There's going to be a whole list of other information that I need to share with you, but for now, this is what I need to know from you. Students who need fit testing, any non-LVHN student, I need your name unless you're only going to St. Luke's. So there is a small group of you that are only going to St. Luke's in the day group. You do not need to do this. In the evening group or in the day group that's going to Lehigh Valley, I need your name. So send me an email and put in the subject line fit testing so that I know. Any student who is not LVHN but was fit tested at another facility, please email me as well. And the Lehigh Valley's response was they need a card or a paper stating your size. So please email me and give me that information. I'm tentatively looking at for the day group starting clinical on 2/12 and the PM group starting clinical on 2/13. And I know there's so much confusion about all the schedules because we're just making changes, and it's not how I like to work, to be honest with you, at all. So let me minimize this and get into get out of chapter 4. Let me get into the clinical schedule just so that you all are seeing what I'm seeing. Let's see, that is day. Okay, so this is the day schedule. I'll minimize it. There we go. Just to kind of give you an idea. So for the day group, my plan, now I'm looking at the weather again, and they're calling for snow again on Friday, 1 to 3 inches on Friday. So my thought is I really want to move forward and give you guys simulation on Friday the 5th, but I do have some wiggle room. I can get you into simulation on April 23rd. That's one plan that I could do. So I can do sim on the 23rd. I could probably do sim. I'm looking to see if I have to. I can actually probably get you into sim on the 12th of February, also a little earlier. And then group 3, I can just send you your assignment. So if I make changes, and I don't like to make them, I really don't like to make them, but if I have to, I want you to have sim. So keep it an ear out. I will definitely email that and post that on Canvas. I would make a decision probably if I'm going to change sim on Friday. I would probably say I would make my decision by 7 p.m. Thursday night. I am going into the school on Thursday afternoon to set everything up, so I would know then. But please keep your ears and eyes open for that. If you do have sim, I'm going to go over for my my first group, which would be hopefully Friday the 5th. Come down here. So take a look and see if you have sim AG or sim BG. And then if you come down here, sim AG is 7:30 to 10:30. Sim BG is 11 to 2. All right. Another thing, it is extremely important. Let me get back to my PowerPoint here. Another thing that is extremely important, and I didn't put this on my slide, I cannot take any chances with anyone coming to sim or to clinical if they have the inkling that they were exposed to COVID. Let me repeat. I do not want you coming to sim or to the school or to clinical if you feel that you were exposed to COVID. Once I get documentation, because you'll probably need to get tested, once I get documentation, you will not be penalized, or should I say, you will not have points deducted for that. I will give you a virtual clinical assignment, but I do not want anyone exposing anyone else. Okay? We're so close to hopefully seeing, light at the end of the tunnel of this pandemic. So anyway, revisit this. I need the names of anyone who has never been fit tested. And I need the names of those who have been fit tested at another facility. If you have been fit tested at Lehigh Valley already and you have your fit test card, you do not need to be refit tested. Okay? If you have been fit tested at Lehigh Valley, you do not need to be refit tested. St. Luke's is going to be going with a KN95. We're not going to St. Luke's until the last 3 Fridays of the day schedule, so I have a little bit of wiggle room to work and get you guys up to speed. But I want to get my Lehigh Valley students up first. All right, some more information, and these are really important things that I really just need to get this information to you guys. So next week, we're having the sexual assault nurse examiner come and do a presentation on intimate partner violence and human trafficking. That is testable material. I am going to upload her PowerPoint under module 1. It's actually there. I just didn't open it up yet. I didn't publish it yet because I'm waiting to see if there's any changes on her end before giving you her PowerPoint from last semester, only to find out that she made changes to her PowerPoint, and then you're getting confused because you have 2 different PowerPoints. So I have that unpublished at the moment. I will publish it, and to be honest with you, students rock on her content. She does a great job. She's a nurse for Lehigh Valley. So that'll be next week. Now she is at this point, due to her busy schedule, because most of the educators at the hospital are also being having different roles as far as COVID vaccinators and working throughout the hospital in different venues. She probably will only be able to be live/remote on Morgan. And then I'm going to record her. She gave me absolute permission to record her, and I will present that to all cohorts. Group presentation topics. Please submit your presentation topic by this Sunday. And I only want 1 submission. So if there's 5 people in your group, only 1 person needs to submit it into Canvas. The other 4 people, it'll show in Canvas that it is not graded. It's just, we don't need 5, every single person putting in there. So just pick 1 person to be the spokesperson, submit a Word document, the title of your topic, and the name of the people in your group. I will respond in Canvas, and I will either say complete or incomplete, complete, and I will say, yes, I approve this topic. I might give you some hints on some recommendations to change the titling of it. And, or I'll say, that's not really going to work, or that's already been done by another group. So please can come up with a different topic. CLGs, I'm in the process of grading those. They take a while because I do go through and really read them. What I decided to do is make a general list. So as I've been reading them, I give you some little comments, and then I've been making a list because probably maybe 50% or more, some of you are not, are maybe didn't put any of the dates of those testings, like the MSAFP or the giving the ROGAM or something like that. So I'm going to make a general list of everything that I was looking for, and I will post that on announcements. As a matter of fact, I'm working on it now. I just didn't publish it because I want to finish and see if there's anything else I need to add to that. So please submit that on time. I had a couple of students asking me if there is, do they lose points? And I did put in my syllabus. So hopefully you saw that I take 1 point per day off of your professionalism grade for late submissions on your CLGs. When it comes to clinical assignments, if a student does not submit a clinical assignment in time and they've reached out, like say it was due at 1:30 for day group, for example, and I know there was a little glitch on that, and I did talk with the clinical instructors, but it is due at 1:30 before post conference. Say you're just really struggling, you're just taking, really having a hard time. You can't get satisfactory in the module, and you have to go back and repeat it 2 times. Then communicate that with your instructor. We actually can see your time on our end. So, communicate. If we see you've been spending 7 hours in it and you still didn't complete it, you need another hour or 2, that's fine. Reach out, communicate with your clinical instructor. If not, that will count as a clinical makeup. If you don't come back to post-conference, that counts as a clinical makeup. If you're greater than 5 minutes late trying to arrive for pre-conference, that counts as a clinical makeup. So just please really be careful. I don't want to add makeup if I don't possibly have to. Because first of all, we have to bring the clinical instructors in an additional week. And also it's May. So once you graduate and start taking your boards and working as a nurse. All right, simulation. So this is, I will post this for everyone, but I just wanted to show you what your prep work is. So simulation, as you see, is only 3 hours. So you do have a little prep work that I need you to do ahead of time. Now, it depends on your time. Some students have Sim A, some have Sim B. Sim A is 7:30 to 10:30. Sim B is 11 to 2. So prior does not mean the day, you're showing up at 7:30. Prior to the day of simulation, watch the newborn assessment video and watch the postpartum assessment video. Okay, so that is extremely important. I know there's a B there. Don't worry about it. There's no more B. It's just A and A. Bring with you newborn assessment and postpartum assessment checklists, and they will be in Canvas for you. So please bring those with you. And then I just gave you some light reading. I didn't have you do the chapters, but in your ATI, which is like a shortened down version, I want you to look at chapters 17, 20, and 23. In chapter 17, I want you to read postpartum physiological adaptations. In chapter 20, postpartum hemorrhage only. And in 23, newborn assessment only. And then you have 4 templates that you're going to do, ATI templates, 2 medication templates, and 2 skill templates. The medication templates are methergine and oxytocin, and the skill is Foley catheter and IM injection. Now, I do realize that you have methergine and oxytocin as a med card for one of your CLGs. Just save that, and when you need to upload it for your CLG, you have that done. So I'm not asking you to do it a second time. I do want to stress it. We are starting simulation at 7:30. So please plan on being there at 7:15 so that at 7:30 we can start. We have 3 hours and we have a lot to cover. So if we're waiting for people, well, after 7:35, I'm not going to admit you. So, but if we're, if everyone's there 7:15, 7:20, I can sign everybody off and we can be ready to rock and roll at 7:30. And the same thing if you show up about 10:45, and then we can sign everybody off and get started at 11 o'clock. So it's like you're working on the floor. If your shift starts at 7, you don't roll to the floor at 7 and start getting report. You usually roll in about quarter of. I have a maternity escape room. We were going to do this today or Wednesday with the group. I was going to put you in breakout sessions, which would have been really fun, but I want you to be able to do that. So I have the answers for you. So what I want you to do is go through this first without the answers. And then I'm going to just give you a quick snapshot of the answers. Maybe. There we go. There's the answers. Let me go back. Boop. Okay. So you do have the answers to go back and check yourself. So if you've never used an escape room before, they're really cool. So I'll take you into it. So this is your maternity escape room. So the first thing you're going to do, are you up to the challenge? Yes. Bring it on, right? All right. And then and you read the directions. I'm not going to read all those for you, but we'll do the first one together. So what this is just to make sure that you kind of know how to navigate an escape room. Write down your answers. So if you're going to do these again in groups as well, but write down your answers. What is Disney's famous female mouse's first name? You should say Minnie. So your answer, you're going to write down 2. Where is she from? Disney. So write down 1. Who does Minnie hang out with? Mickey. Write down 3. So now you should have written down 2, 1, 3. So you need to enter that code to unlock the door. So then we're going to put in here 2, 1, 3. And I'm going to just show you, say you got it wrong, 2, 1, 2. Up, they told me to try it again. So let's try this again. 2, 1, 3. Bam! It brings you to the next one. And then you're going to go through that. You're going to answer the questions and then continue. I would recommend keeping your textbook right next to you, or open it up if you have the Davis online and use that as you're going through. All right, so that is your escape room. There are the answers to go back and check. All right, some NCLEX questions for you. I'm going to just go through these kind of quickly. You have the questions on your PowerPoint, so I'm just going to, you can pause these and then answer them and then check your answers. So I'm going to just, for time purposes, I'm going to kind of go through these quickly. So the nurse is caring for a couple who is being evaluated for infertility. Which of the following statements by the nurse indicates understanding of the infertility process? And certainly hit pause here so you can work on it on the video, but I am going to go to the next slide. And your answer should be C. The man is the easiest to assess and the provider will begin there. Always think least to greatest, least invasive to most invasive. Dosage calculation. The client weighs 132 pounds. Heparin is ordered at 8 units per kilogram per hour. The IV solution is 250 milliliters of D5W with 25,000 units of heparin. At what rate will you set the IV pump to administer the prescribed dose? And you should have 4.8 milliliters per hour. Human chorionic gonadotropin, HCG, 8,500 units is prescribed IM. It's available 20,000 units in 5 milliliters because it's a multi-dose vial. How many milliliters should be administered? So pause. I'm going to go to the next slide. You should have 2 milliliters. First day of, you're going to calculate the due date. First day of last menstrual period is August 20th, 2019. Go ahead and pause. And the answer is May 27th, 2020. You're going to calculate the GTPAL. Remember, this is all kind of a review from last week. A 30-year-old female is 25 weeks pregnant with twins. She has 5 living children. 4 of the 5 children were born at 39 weeks gestation, and 1 child was born at 27 weeks gestation. 2 years ago, she had a miscarriage at 10 weeks gestation. What is her GTPAL? Now, on the exam, for exam 1, it's not going to be multiple choice. Exam 1, you will have to fill it in. Unless I change my mind by then. We'll see. So you should have G7, T4, P1, A1, L5. All right. So we're going to start with antepartal tests. And this is pretty straightforward. So this isn't very difficult, this content. So antenatal means during pregnancy. So these are the tests I want you to focus on. Hint, hint. Ultrasound, amniocentesis, maternal serum alpha fetoprotein. You hear the word serum in it. What type of a sample is maternal MSAFP, maternal serum alpha fetoprotein. That's a blood draw. Multiple marker screen, that's a blood draw. Fetal movement count, that's teaching the woman how many times they feel the baby kick and move. Non-stress, contraction stress, and biophysical profile. Please make sure you know these. I'm going to show you a little video on ultrasound.
On ultrasound, fluid is black, bone will be white, and other tissues are shades of gray. This is the patient's bladder, and the fetal head is down near the cervix. The position of the fetus doesn't matter at all at this point in time. We often see the fetus completely flip around during the course of the ultrasound. The placenta is on the front side of the uterus. We want to look at that location relative to the cervix. But this early in pregnancy, even if it is low, there's a good chance it'll move higher later in pregnancy. This is the umbilical cord connecting to the placenta. We check to make sure the attachment is normal. When we look closely at the umbilical cord, we'll see 2 small black circles and 1 black stripe. Those are the 3 blood vessels in the cord, which is the correct number to have. We want to look closely at some structures inside the brain. The bright area here is the choroid plexus, the part of the brain that makes spinal fluid. This black area next to it is the collection of spinal fluid in the brain. We measure it to make sure there isn't hydrocephaly or too much fluid in the brain. We also look at this structure in the back of the brain, the cerebellum. It looks like 2 balls stacked on top of each other. For years, all we did was measure it for growth, but we now know the shape may be changed if a baby has a neural tube defect. So looking at this area helps us detect spina bifida. In this view, we also measure the thickness of the skin at the back of the neck. It can be increased in some chromosome abnormalities like Down syndrome. Here we're looking directly at the face, which looks more like a skull. There just isn't much fat yet on the face. Within the eye socket, you can see something that looks like a bubble. It's the lens of the eye. We also want to look at the lips and nose, which are behind the baby's hands. You can see the nostrils appear black because they fill with amniotic fluid. If there's a gap in the lip, a cleft lip, it also fills with fluid and will appear black, so you don't see the nice gray outline of the upper lip. The profile is good to look at for a couple of reasons. First, it's a pretty image that most people can easily recognize. But more importantly, there are times when the chin is too small, which can potentially cause problems for the baby with breathing in the delivery room. We want to see the nose, the lips, and the chin in a nice straight line. This is the spine. We look at the region of the neck, the middle of the back, and all the way down to the sacrum or tailbone where it comes to a V. These views help us detect spina bifida. You can also see the ribs coming off the back. With the spine up towards us, we can also see some of the big blood vessels in the baby, like the aortic arch, the black candy cane-shaped structure in the chest. The heart is one of the most important organs that we look at during an ultrasound. It appears black because blood inside the fetus is really just another kind of fluid. That allows us to see the 4 chambers of the heart valves opening and closing, and the blood vessels leaving the heart. There's a hole here between the right and left sides of the heart. It allows oxygenated blood to take a shortcut from the right side of the heart to the left side and bypass the lungs since oxygen is being provided through the umbilical cord. That hole will close after a baby is born. These colors represent blood flow in the heart and help us to see that both sides of the heart have developed normally and are being filled with blood. The kidneys sit next to the spine and are hard for me to point out to people and show them that they're normal. Here we're looking at a cross-section of the abdomen at the level of the waist. The black dot is the baby's stomach, and it shows up as black because it has fluid in it. The fluid is amniotic fluid, which the baby has swallowed. So seeing it there tells me that the baby is swallowing, which is an activity that should be happening. And since the fluid makes it down into the abdomen after the baby swallows, we know it is unlikely that there is a blockage in the baby's esophagus. Looking further down, we see these little lines. That's where the umbilical cord is actually attaching to the baby's abdomen, so the future side of the belly button. We check to make sure that that part of the abdominal wall has developed normally. And finally, all the way down in the baby's pelvis, we see another black dot, which is the baby's bladder. That tells us that the kidneys, which earlier we saw appear normal, are functioning and producing urine. Here are the baby's legs. They are extended and we see both of them moving. I also want to look at the position of the feet coming off at the ankles and make sure they're nice and straight with no evidence of a club foot. That's where the foot is turned in or out. And finally, these are the bottoms of both feet, like footprints. We're at the end of our head to toe look at your baby's ultrasound, and I hope you've learned a little more about what that ultrasound is telling us.
All right. So this just kind of goes over again what the ultrasound is telling you. So presence of that gestational sac, fetal activity, number of fetuses, amount of amniotic fluid, visual assistance. So they will do an ultrasound guided amniocentesis. Why do you think we would do an ultrasound guided amniocentesis? Right. So hopefully you said because when they're going in to do the amniocentesis and they're inserting the needle into the abdomen to go into the amniotic fluid, they want to know where the heart, the brain, all that is with the baby before they put the needle in, right? External abdominal ultrasound, it's non-invasive. An ultrasound transducer is moved over the abdomen to obtain an image. The client needs to have a full bladder, so it's caused a lot of discomfort for the woman. Transvaginal is just as it says. So the ultrasound probe is inserted vaginally. This is this is a invasive procedure, doesn't require a full bladder, and this allows better visualization in a more obese client. All right, so amniocentesis. Now I know you have a link for this. When I go in and actually, it wasn't letting me play it right off of here. I'll see if it does now. Okay, so you have to go like this.
When school isn't a place you have to be, why not go to school where remote learning can be as remote as you want?
Amniocentesis is a procedure that lets doctors detect or rule out problems with your baby's health long before birth. In the uterus, your baby is surrounded.
Pause. When you first saw that, you saw that they were doing the ultrasound at the same time that they were ready to do the amniocentesis. So you'll see that.
By amniotic fluid that provides protection and nourishment. Floating in the fluid are cells from your baby, providing doctors with genetic material for testing. In amniocentesis, your doctor will take a sample of this fluid to test for specific genetic disorders and birth defects. Amniocentesis is usually done in the second trimester of pregnancy, at 15 to 18 weeks. It is generally offered to women with certain risk factors, age 35 or older, which increases the risk of chromosomal disorders such as Down syndrome.
Hint, hint. Remember this.
Previous child or pregnancy with a birth defect, blood test or ultrasound suggesting a birth defect, such as Down syndrome or neural tube defects, or a family history of genetic disorders, such as cystic fibrosis. Amniocentesis may also be done in the third trimester for these reasons: to determine if the baby's lungs are mature enough should early delivery become necessary, to diagnose a uterine infection, or to check for anemia in a baby with Rh incompatibility. To begin your procedure, your doctor will use ultrasound to create an image of the fetus and nearby structures on a computer screen. Looking at this image, the doctor can choose a safe place to insert the needle. Your doctor may give you an injection of local anesthesia to numb the surface of your abdomen, where the amniocentesis needle is to be inserted. Carefully watching the ultrasound monitor to avoid contact with the placenta or the baby. Your doctor will introduce the thin needle through your abdominal wall into your uterus and into the amniotic sac. He or she will then withdraw a small sample of amniotic fluid, remove the needle, and cover the site with a bandage. Your body will make additional fluid to replace what was removed. Your doctor will continue to monitor the ultrasound to check that the fetal heartbeat is normal and the baby tolerated the procedure well. You may feel mild cramping or pressure in your lower abdomen. For about 24 hours after your procedure, You will be advised to avoid physical stress, such as vigorous exercise, lifting, prolonged standing, and sexual activity.
I'm going to pause there. Hint, hint, make sure you know the general education that you need to give a woman post an amniocentesis. Think of a thoracentesis. So you've learned about thoracentesis in med surg, right? So think about the same things hold true, except you also have to remember that she has a baby. So you have two, excuse me, two patients versus one. I think that was it. Okay. Any questions so far? And I know I'm doing this online, but jot down any questions, take a moment, pause, think of any questions, put them in the Q&A, because if you have a question, probably your classmates have a question as well. Okay, so amniocentesis just goes over what we just talked about. Post amniocentesis, you want to monitor vital signs. You monitor the fetal heart rate, FHR, fetal heart rate. You want to identify if she's having any contractions. Have the client rest for 30 minutes afterwards. And this is very important. Make sure you know this. This is one of those times, if mom is Rh negative, that you're going to administer RhoGAM. Why do we administer RhoGAM if a mom had an amniocentesis? Because is there a chance that the maternal and the fetal blood can mix? Absolutely. So hint, hint, when you're studying for your test, know all of the different times when a mom who is Rh negative is going to need RhoGAM. This is one of them, okay? So you want to tell the mom to report any fever, chills, leakage of fluid or bleeding, decreased fetal movement, vaginal bleeding, or uterine contractions. Make sure that she increases her fluid and gets a lot of rest post 24 hours the procedure. So these are those times when a lot of this content is built on foundational information, background information, fundamentals information, basic med surg information. So if you're not sure, it's been a long time that you've been in class. You know, if you're an LPN, you haven't addressed this stuff in a long time, I would go back to those med surg books, go back to and just revisit. And the test that comes to mind for me is like a thoracentesis. Okay. So the next test is a blood test. It's maternal serum alpha fetoprotein. MSAFP is the abbreviation. And this is done about 15 to 20 weeks gestation. This is optional. This is not mandatory. We have a lot, well, anything. I mean, if the mom refuses, the mom, refuses, but this is not mandatory. It's a blood test that is going to be detecting neural tube defects. There is a chance that it has a false positive, and you want to really educate the family and be working with genetic counseling with this. The next one is quad screening. And what is the difference between the quad versus the MSAFP is the quad can identify 60 to 80% of the cases of Down syndrome or the chromosomal disorders. Again, done about 15 to 16 weeks. It's more reliable than the MSAFP. So it covers a lot more. So your book goes into detail about both of these. Just make sure you really understand the difference between MSAFP, which is more for your neural tube defects, and your quad screening, which will cover your neural tube defects, but it also goes into your chromosomal disorders, such as Down syndrome. And just as a reminder from last week's lecture, what is an example of a neural tube defect? Spina bifida, right? Okay. Antenatal fetal surveillance. So it's basically known as kick counts. Your book goes into a lot more detail. So basically, you're teaching the mom to check for 10 distinct movements or kicks of the baby within a 2-hour period. And then you're looking at the fetal heart rate, your non-stress test. You're looking at your fetal heart rate and accelerations. So your non-stress test is looking at the fetal well-being. Let me reiterate that. The fetal well-being, the non-stress test. It's non-invasive, and it's going to monitor the baby's response of their heart rate to their movements. Biophysical profile, very important. I would hint, make sure you know this. It looks at 5 indicators, and let's talk about those 5 indicators. The first one is fetal heart rate. The next one is fetal breathing movements. The third one is fetal movement, fetal tone, and measuring of the amniotic fluid. So your biophysical profile looks at 5 things: fetal heart rate, fetal breathing, fetal movement, fetal tone, and measures amniotic fluid. The multiple marker screenings identify A, neural tube defects, B, cerebral palsy, C, hemolytic diseases, or D, cleft palate. Neural tube defects. Also identifies Down syndrome. All right, so that's the end of your antenatal diagnostic tests, your fetal surveillance. Review your ATI. There's a lot more information on that, chapter 6 and chapter 5 in your ATI. So always go back to that as well. Any questions, write them down, put them in the Q&A. All right, so the learning outcomes here, we're going to talk about the complications of pregnancy. We're going to talk about complications, tests, diagnosing, and managing high-risk conditions, and talk about potential antenatal complications to the woman, the fetus, and the newborn. So risk factors: pre-existing health conditions, prior complications, overweight, obesity, carrying multiple fetuses, being very young, and being very old. Hint, hint. So they are your risk factors for having a high-risk pregnancy and having complications. First one we're going to talk about is preterm labor or premature rupture of membrane. So PROM, premature rupture of membranes. So as you're taking your notes, preterm labor is regular contractions. And we're going to talk about labor a little later on, but to give you an idea for preterm labor, hint, hint, you're going to see a change in the cervix before 37 weeks. That's actually going to be one of your positive signs of labor, is cervical changes and cervical dilation. Threshold of viability. Actually, I think we could probably lower that now. What did Rich say? I think he said 22 weekers now. 23 is where 22 is still not doing too well. So 23. The 25 is what they say is the threshold, but we're seeing it's a lot earlier now. Anything lower than that, they have a poor survival rate and a high mortality and morbidity rate. But there are miracles, I have to say. So risk factors, a whole host of them. So infections, big thing. So these women, even these UTIs, kidney infections, previous preterm, twins, triplets, quadruplets, having excessive amniotic fluid. Remember the term for that? Polyhydramnios. The age, Socioeconomic status. Intimate partner violence increases the risk for preterm labor. Intimate partner violence. History of multiple miscarriages or abortions. And then chronic conditions such as diabetes and hypertension. History of preeclampsia. Lack of prenatal care. And you kind of see that lack of prenatal care kind of tied with your intimate partner violence. There's low socioeconomic, substance abuse, smoking, drinking. Placenta previa or abruptio placenta, where the placenta is separating from the uterine wall. And then premature rupture of membranes. And then short interval between pregnancies. So that's when the mom comes home, has the newborn, and is pregnant within less than a year of the next child. So a lot of risk factors, know them. So how is preterm labor diagnosed? And I think you kind of had this when you did the GTPAL, remember? So preterm labor is birth between 20 weeks and 36 and 6/7 weeks. Preterm labor is diagnosed by those regular uterine contractions, and I just talked about in the slide prior to that, changes in cervical dilation and effacement or both. Let me say it again, changes in cervical dilation or effacement or both. Medical management, really important, is you want to delay that preterm labor as long as you can. If the further along we can get that woman in her pregnancy, the higher the survivability is of the infant. So for mom, we want to administer antenatal steroids. Hint, antenatal steroids. What will be an example of an antenatal steroid? Good, so betamethasone. And the reason we're giving these antenatal steroids is that is given to mom, but these antenatal steroids are going to help the fetal lungs to mature. That is the only reason we're giving her these antenatal steroids, is to help those fetal lungs to mature. We want to delay delivery for at least 48 to 72 hours, so we can get at least 2 doses of these antenatal steroids into mom. And again, an example is your betamethasone. So they have a host of medications that we can use to stop labor. Know the term tocolytics, because sometimes I'll give the medication, or sometimes I'll say administer a tocolytic. So in medical terminology, toco means to, lytics means to stop, like lysis of adhesions. So tocolytics is to stop labor, medications to stop labor, to allow the administration of the betamethasone and or get that mom transported to a higher level of care. So I think for me, like in my area where I live now, it's this no longer, but we had a small hospital called Palmerton Hospital. They are just basically, they could stabilize, but they're not a high level. They don't have a high level NICU. So we would get mom stabilized and then get her transported to a facility that can manage these really young neonates. Make sure you know your drugs. I'm going to go through them. So the first one is your calcium channel blocker, and that is your nifedipine or your Procardin. Now think about this. Go back to med-surg, because this is what really tricks some students up, is they put blinders on. Those blinders that the horses, those driving horses that you see either downtown Bethlehem or in Lancaster, and they have those blinders on. So don't put blinders on and think, I'm in an OB course, so I don't need to really remember my med-surg stuff, because that's definitely not true. So think about when you were giving medications or even learning about medications, because clinical has been, clinical this past year and a half. What would you expect if you're giving somebody a calcium channel blocker? And so those types of things that you would be looking for or educating with the patients on your med surg unit, you're going to do with your mom. So how the procardia or the nifedipine works, it's basically stopping those contractions because it inhibits calcium from entering the smooth muscle. So that is physiologically what's going on. What you want to have the mom monitor for is orthostatic hypotension because it's going to drop her pressure. And remember, most of these moms do not have a problem with pressure unless they have preeclampsia. So you want to have her get up slowly, monitor for headaches, flushing, dizziness, nausea. So be really careful when you're studying these medications. Okay, the next one is indomethacin. And indomethacin, yes, it's an NSAID, right? But it's also used to halt preterm labor because indomethacin has the function of blocking prostaglandins. So thereby suppressing the uterine contractions and stopping the preterm labor. You want to monitor for respiratory issues with this indomethacin. So having really good assessment skills, especially lungs, is really important. Again, people think that they're in OB. It's not, some of those assessment findings, your assessment skills are not needed. They are very much needed. This is how you're going to be identifying anyone having a PE, anyone going into pulmonary edema. So you want to be listening to these lungs and doing a good respiratory assessment. You want to monitor for postpartum hemorrhage. Think about giving her an NSAID. So we want to watch for bleeding. It has a tendency to upset the stomach. So give this with food, and also have educate the patient to notify the provider if they have any blurred vision, headache, nausea, vomiting, or difficulty breathing, and monitor the baby at birth. The next one is your beta adrenergic receptor agonist. This is not FDA approved. I still just discuss it, but they really are not using it much, but it's still testable in NCLEX. So I still talk about it, but in the real world, you're not seeing it as much. So it's a beta adrenergic agonist. It is a potent cardiovascular stimulant. So they see this has more risks than benefits. The next one is magnesium sulfate. And what this does is it's going to relax the muscles of the uterus, thereby inhibiting uterine contractions. So this is a really important med. You're going to hear about this med now. You're going to hear about this med when the mom has preeclampsia. And if you're iffy on your neuro assessments, go back to your neuro assessments and really make sure you have a good understanding of your neuro assessment when you're when you have a woman on MAG. So it's contraindicated with active bleeding, dilation, greater than 6 centimeters, greater than 34 weeks gestation, acute fetal distress. You want to, again, monitor closely for pulmonary edema. So your respiratory assessment should be astute. And the biggie, hint, is monitor for magnesium toxicity. So know your DTRs, your deep tendon reflexes. If you don't remember your deep tendon reflexes, I highly recommend you go back and revisit that. We'll talk a little bit about it. So you want to monitor for magnesium toxicity. And also remember last week when I talked about the labs and I said the labs are different when someone's on a MAG drip, right? When they're on a MAG drip, their MAG levels we're not looking at that 1 to 2, we're looking more at that 6 to 7 range. So go back and revisit those labs in your Canvas shell that I showed you. So monitor for mag toxicity, loss of deep tendon reflexes, key. Low urine output, key. Respiratory depression, key. And pulmonary edema, key. So very, very important. What is the antidote? What can we give to reverse mag sulfate? Calcium gluconate, right? Calcium gluconate. The next one, we talked a little bit about this in the beginning. So your corticosteroid or your betamethasone, it's going to be administered 12 milligrams IM in 2 injections, 24 hours apart. That's why we want to try to have that 24 to 48 to 72 hour type period. It's going to enhance fetal lung maturity and surfactant production. We haven't talked about surfactant production, have we? So make sure you understand about your surfactant production. The surfactant is usually not produced till to about the 24th to 34 week, and even then it's decreased. And basically, it allows the alveoli in the lungs to remain open. And babies who have a decreased amount of surfactant are said to experience respiratory distress syndrome. So some nursing considerations for the betamethasone. It's a steroid, right? So go back. I know you probably are like, will you stop saying go back to med-surg? But go back to med-surg. Think about, what does a steroid do? It's going to increase your glucose level, right? So what if this mom has gestational diabetes already? So this mom already has diabetes during pregnancy, or she has type 2 diabetes or type 1 diabetes, right? So we're going to really watch her blood sugars. We want to assess the baby's lungs, position her on her side to increase uteroplacental perfusion, and assess that heart rate and those uterine contractions. Premature rupture of membranes. I'm not going to play this little video on cerclage. It's a procedure that they could also use to stop the preterm labor. And then they would put the woman on bed rest, and they basically do like, they kind of stitch the cervix closed, and then they have to take those stitches out prior to delivery. So take a look at the video. It's very interesting. Multiple gestation. So know your terms, your monozygotic and your dizygotic. So your monozygotic are your twins that come from one zygote. Think back to A and P, right? They are genetically identical and similar in appearance and always have the same gender, because your moms might ask you that. The dizygotic, hint, hint, twins from fertilization of 2 eggs and may be the same or different genders. And always understand that these babies, or these moms that have multiple gestation, have an increase in complications and preterm labor. Next thing we're going to talk about is hyperemesis gravidarum. Hyperemesis gravidarum is much worse than the morning sickness that most women experience in the first couple of months of pregnancy. This goes way beyond this. This is morning, noon, night, week 4, or I'm sorry, month 4, month 5, continuous. Woman's losing weight. The baby's not getting enough. That's hyperemesis gravidarum. It's excessive vomiting during pregnancy. It leads to dehydration, electrolyte and acid and base imbalances, hospitalizations, IV fluids. The mom might actually be put on TPN. So it's much more severe than your general morning sickness. But what would be a nursing diagnosis? Think about, what if you had to write a care plan for a mom with hyperemesis gravidarum, what would be a nursing diagnosis? Nutrition, right? Nutrition would be a big one that I would think of, right? And the baby might actually have intrauterine growth restriction. All right, the next thing we're going to talk about is gestational diabetes. So I'm going to show you a little video on gestational diabetes.
Hi, I'm
I'm Dr. Siobhan Dolan, and I'd like to talk to you about gestational diabetes. Gestational diabetes is a medical condition that causes very high blood sugar levels during pregnancy. If you develop gestational diabetes, it's important to know how to manage it and keep it under control. Gestational diabetes is a kind of diabetes that some pregnant women get. It usually develops after 20 weeks of pregnancy. Even though it usually goes away after you have your baby, having gestational diabetes makes you more likely to develop diabetes later in life. Gestational diabetes can cause problems during pregnancy, like your baby may be born premature, before 37 weeks of pregnancy. Premature babies are more likely than full-term babies to have health problems at birth and later in life. Your baby may be very large and weigh more than 9 pounds. Weighing this much can make labor and birth more complicated, sometimes causing injury to the baby. You may develop a kind of high blood pressure called preeclampsia. You may have trouble during labor and need to have a C-section. Your baby may be stillborn. Your provider gives you a glucose screening test between 24 and 28 weeks of pregnancy to see if you have gestational diabetes.
I'm just going to pause there. So when did she say that you're going to have the glucose tolerance test? So between 24 and 28 weeks. So remember I was talking about your CLGs, and that was one of the things I was talking about, is when you guys were writing down these different labs, is know the time frame that these labs are going to be done.
If your provider thinks you're at risk for developing gestational diabetes, he may test your glucose levels earlier in pregnancy.
Hint, hint.
Are you at risk for gestational diabetes? You're more likely to develop gestational diabetes if you're older than 25, you had gestational diabetes in a past pregnancy, you were overweight before pregnancy, or you've gained a lot of weight during pregnancy, members of your family have type 2 diabetes, you had a baby in a previous pregnancy who weighed more than 9 pounds or was stillborn. How is gestational diabetes treated? If your glucose screening test comes back positive, you get another test called a glucose tolerance test to see for sure if you have gestational diabetes. If this test is positive, your treatment may include going more often for prenatal care checkups through the rest of your pregnancy to make sure you and your baby are healthy. Checking your blood sugar on your own. Your provider shows you how to do this and tells you how often to check it. Eating healthy foods and being active every day. Taking medicine called insulin. It comes in shots that your provider shows you how to give yourself. Remember, you get a test for gestational diabetes at 24 to 28 weeks of pregnancy. If you're at risk for gestational diabetes, you may get tested earlier. Gestational diabetes usually goes away after you have your baby. For more information about gestational diabetes, visit marchofdimes.org.
All right, some really good information. I'm going to use the case study method when I go over gestational diabetes, but please, please, please go back to your textbook and revisit some of these content areas, and I'll try to stress them as we're going through. All right, so we're going to talk about care of the woman with diabetes mellitus in a case study. So our patient her name is Margaret. She was admitted to the high-risk perinatal unit for adjustment of her insulin. She is a gestational diabetic for the first time. Her obstetrical history includes 2 previous infants, both over 9 pounds. Hint, there's one of her risk factors. She's 36 years old. She's 32 weeks pregnant. Remember, where are they checking? 24 to 28, right? She's placed on insulin therapy, which they do. I think actually, I was a diabetic educator for a while as well, with one of my hats that I wore. And when I did a lot of my work with moms, I like that you would use insulin over the medications. I felt that it was much safer for the baby, but some people just have an aversion to injections. But anyway, she was placed on insulin therapy at 26 weeks. So the first thing we want to do is determine the recommended guidelines for screening. So I gave you this link. I want you to go to the American Diabetes Association and go to the gestational diabetes section. So let's do that now. Okay, so let's take a look at these recommendations. The test for undiagnosed diabetes at the first prenatal visit in those with risk factors using standard diagnostic criteria B. So test for gestational diabetes at 24 to 28 weeks of gestation. I hope you're taking notes. 24 to 28 weeks of gestation in pregnant women not previously known to have diabetes. Okay, is everybody with me? Test women with gestational diabetes for persistent diabetes at 4 to 12 weeks postpartum using the oral glucose tolerance test. Women with a history of gestational diabetes should have lifelong screening for the development of diabetes or prediabetes every 3 years. Women with history of gestational diabetes found to have prediabetes should receive intensive lifestyle interventions. Then it goes on to talk about the definition of diabetes, gestational diabetes. And the definition basically is any degree of glucose intolerance first recognized during pregnancy, regardless of whether the woman had this condition previously. Okay, so let's come down to the diagnosing. So the diagnostic criteria that they're going to be used, GDM diagnosing, table 2.6, can be accomplished with either of two strategies. The first one, a one-step 75-gram oral glucose tolerance test, or a two-step approach with a 50-gram non-fasting followed by a 100-gram oral glucose tolerance for those who screen positive. Okay, so the one step, we're going to come down to here, and the one step at 24 to 28 weeks. And I want to take you guys to the ranges of what they're looking, and your book has it as well, but just as we're going through. So in one trial, the 2-hour is 140 was lower. Let me just see here. Really, really good information. I don't know. Is anybody interested in being a diabetes educator? So let's go to that table. Just looking for the table real quick. Okay, this is what I was looking for, the screening and diagnosing. So step one, perform a 75-gram oral glucose tolerance test with plasma glucose measurement when the patient is fasting and at 1 hour and 2-hour intervals at 24 to 28 weeks. The oral glucose tolerance should be performed in the morning after an overnight fast of at least 8 hours. The diagnosing of GDM is made when any of the following plasma glucose values are met or exceeded. So a fasting of 92, a 1 hour of 180 milligrams per deciliter, and a 2 hour of 153 milligrams per deciliter. That is for your 1 hour. or I'm sorry, for your 70, for your first step, for your 75. The 2-step, perform the 50-gram non-fasting and measure at 1 hour at 24 to 28 weeks. And if the plasma glucose level measured at 1 hour after the load is greater than 130, 135, or 140, then you go to the 100 gram. Then the 100 gram, the fasting is greater than 95. That's what I'm looking for. All right. The greater than 95. A lot of people think it's the 105. It's the greater than 95. So just to give you a little idea. All right. I could go in and talk about this all day, but we won't. Okay. So women without previous risk should be screened how many weeks? Okay. So write that down. We went into table 2.6. We clicked view inline, go to the 2-step strategy. And what is the diagnostic criteria for gestational diabetes after a 50-gram oral glucose tolerance test? So there you go. Treatment plan. So you click on here. They have your treatment plan in here. Again, before a meal, preprandial, we want them 95 milligrams per deciliter or less before a meal. 1 hour after a meal, postprandial, 140 milligrams, and 2 hours, 120. So these are the targets that the American Diabetes Association suggests for women who develop gestational diabetes during pregnancy. These are very, more or less, these are very stringent glycemic goals. Why are they so stringent? Right, because we have a baby that we are also watching, and we're going to talk about complications of diabetes on the infant. Okay, so once that woman is diagnosed with gestational diabetes and we're having her doing her finger sticks, before a meal, we want her 95 milligrams per deciliter or less. Match the terms to the condition. I'm going to go through these a little quickly. Whoops, I didn't mean to go that quickly. I'm going to let, if you want to pause just so we can go through. So, you know, if you've already done these and when you did your notes. So you should have A, D, C, and B. Margaret's diabetes was not noticed until her first trimester because, and then there are your choices. So go ahead and pause. And you should have C. There was physiologically less insulin resistance. Remember, you guys did your CLG number 1. We talked about how they are hypoglycemic initially, and then further along they become hyperglycemic. Glucose intolerance in pregnancy is most likely to occur after the 28th week of pregnancy. We're not going to go into teaching groups, but some of the things you want to think about. How does gestational diabetes affect the pregnant woman and affect the baby? So what are some things that you would see with the pregnant woman with gestational diabetes? Basically, here is what I want you to know. Is you're going to be treating the woman with gestational diabetes just like you would care for a type 1 or type 2 diabetic. There are going to be modifications in diet, exercise. They want to have them walk at least 30 minutes a day. They want to check their blood sugar multiple times a day. So they're going to check a fasting. They're going to check a postprandial from breakfast. They may check a fasting before lunch, a postprandial, and so on and so forth. And then they'll take one at dinner time and at bedtime. They want to monitor their blood sugar before they take a walk, carry a snack, at least a 15-gram glucose snack. Same thing we would teach our general diabetic population. The damage that gestational diabetes does is irreversible, just like the damage that is done from diabetes. It increases their risk for diabetes later on. It increases the baby's weight, complications, increases mortality rate, larger for gestational. The baby has, when the baby's born, because they're larger, they have, they can, be born with like a broken clavicle. And so a lot of birth trauma. You're going to go over the same way. How you check your sugar is the same way. Manage diet and exercise, take medications. Your textbook goes into a lot of this. So Margaret's A1C is 15%. Ay, ay, ay. A little overkill there. So what is a normal A1C? So we would like it, less than 5, right? So 4 to 5.6. The A1C is an average measurement of the glucose over the past how many days? So your 3 months to think about your red blood cells. Most women, such as Margaret, are not candidates for oral hypoglycemics since many of them have teratogen effects, which means that they can cause problems to the baby, very severe problems. So insulin is usually used to maintain gestational diabetes. That's what I want you to know. I'm not going to get into the oral agents for it. Insulin is generally the med of choice. This is just a nice, I'm not going to go into a lot of it, but this is, if you're doing meds, this is another nice resource. It's called Hippocrates. How many use Hippocrates now? So you click on, you have to create an account. Let's see, I should still have my account. All right, so I don't remember my account. That just takes you through. Really nice. I would definitely use that. I would go back and just do this after you make an account. I'm not going to do it because I can't remember my account, my password, but go through and do that. Daily fetal movement counts are to be done now and every day. Margaret should feel blank fetal movements in 2 hours. And we talked about that a little bit ago. So your answer should be 10. Now they're going to do a non-stress test. We talked about that with our antenatal test. They're going to do a non-stress test to get some information. They do have a little YouTube video as a tutorial if you need it.
Fetal monitoring may be used at different times during your pregnancy and during labor to assess your baby's well-being. The fetal monitor uses ultrasonic waves to pick up your baby's heartbeat. This is converted to a heart rate, which is displayed as a number on the left side of the monitor and recorded as a variable line on the graph paper. The fetal monitor can also be used to monitor the frequency and duration of your contractions, but not the strength of the contraction. The contraction will be displayed as a wave or hill pattern on the graph paper and on the large screen above the monitor. Your nurse will place 2 soft, stretchy Velcro straps around your abdomen to hold the 2 transducers in place. Ultrasound gel will be applied to the transducer, which is placed on your lower abdomen to pick up the baby's heartbeat. This works in a similar way to the Doppler used in your doctor's office. It's not uncommon for the nurse to have to adjust the placement of this transducer during monitoring as the baby moves around. The second transducer, which is called a TOCO transducer, is pressure sensitive and will be placed on your upper abdomen to record the contractions. If you are having twins, you will have 2 transducers to pick up the baby's heart rates and 1 to record your contractions. The second heart rate will appear in the center on the monitor. The non-stress test is used to assess your baby's well-being by monitoring your baby's heart rate while you are resting and the baby is not being stressed by contractions. Your nurse will connect you to the monitor and record the baby's heart rate for about 20 to 40 minutes. A reactive or normal test will show that the baby's heart rate has variability within a normal range. A non-reactive test may indicate that the baby has health issues which need to be further assessed. When you are admitted in labor, your nurse will use the external fetal monitor to check your baby's heart rate and your contractions. After an initial period of monitoring, you can be disconnected from the monitor to walk or use other comfort measures. Your nurse will periodically reconnect you to the monitor to check your baby's heart rate, but you do not need to remain in bed for these checks. The monitor cords are long enough for you to walk around the bed or sit in the chair. If you are induced, if you receive medication to augment your labor, or if you receive an epidural for pain management, your baby will need to be monitored continuously until delivery. Epidural patients will also need to remain in bed.
All right. So don't get hung up on this. We're going to go over this further down, but just this woman Margaret had her non-stress test done. How many fetal accelerations are there? So fetal accelerations are the normal heart rate is 120 to 160. So how many times did it go above? So take a look at that there, and you can pause that, and you should have gotten 7. Should have 7. So education, at-home monitoring education was provided to Margaret when she came in for her one-to-one ed session with the diabetic nurse educator. And then what are some concepts the nurse educator should have gone over with Margaret? So think about that. All right, so hopefully you paused and wrote down some education that you would be doing. So one of the things we would talk about with the mom is the risks of having diabetes during pregnancy. So we would talk about congenital defects. Congenital defects are a risk factor, hint, hint, to a newborn born to a mom with gestational diabetes. They could be cardiac, skeletal, neurological, genitourinary, GI, related to maternal hyperglycemia during gestation. Other things, macrosomia, related to fetal hyperinsulinemia. So that high level of glucose can cause larger than normal newborns. These babies are used to this circulating glucose. So when these babies are born and you cut the cord, the baby's pancreas is very immature, so it may still be producing insulin, but now there's no circulating glucose in the baby's system, so the babies are at high risk for hypoglycemia, which can cause respiratory distress syndrome, hypothermia, so a lot of issues. You want to talk about self-management to the mom, so self-monitoring of her glucose. So she's going to be checking her sugars 4 to 8 times a day, before and after meals, at bedtime. You want to remember sick day management, same as what we would teach our regular diabetics. Checking for ketones, keeping strict records. And remember, what is that fasting? Normal pregnancy glucose values, and for pregnant women with diabetes, what do we want their target blood glucose for pregnant women with diabetes to be? A fasting of what? Less than 95, right? 1 hour after meals, less than 140. 2 hours after meals, less than 120. Medical nutritional therapy. So you want to make sure that she is seeing the registered dietitian as well. So when I used to, again, work as a diabetic educator, we were a great team. It was us. It was me, the diabetic educator, the GYN doc, and sometimes, depending on if they had like type 1, endocrinology would be involved. Again, risk of complications during delivery. You want to really watch that baby for any low blood sugars, respiratory distress, issues like that. Let's see. Is there anything else I could think of? Good glycemic control is extremely important. So you want to make sure that you talk to mom about that. I told you about like things like shoulder dystocia. So birth injuries are a risk for the fetus. Hyperbilirubinemia, so high levels of bilirubin. Risk for the women, preeclampsia, increased risk of C-section, develop of type 2 diabetes later on. Trying to think. Make sure the woman is an active participant in her care. Teach the woman signs and symptoms of hypoglycemia. Teach her signs and symptoms of hyper, how to manage. Walking is always good. So, pregnancy outcomes are greatly improved among women who have strict glucose control. Fetal risk and infant morbidity and are kind of correlated to the glycemic control. The better the glycemic control, the better the outcome. The worse the glycemic control, the poorer the outcomes. So just to keep you there. Hopefully you said all that. What I would do when I'm studying, and I've seen this with some of my other students, is concept mapping. Concept mapping is a great way to study. You take these concepts, you take this GDM mom, and you just kind of build it out. Let's see if I can, just for the heck of it. So here's some different ones. I'd have to pull it up to see. No, they didn't really put a lot of information into it. There you go. All right. Anyway. The nurse understands that further teaching is needed when the patient states, and again, I'm going to kind of go through there. So should be B, I should check my glucose before I eat if I feel weak. Yes, you should eat first. Margaret takes Humalog and Lantus in the morning and Humulin N at night. She rotates her injection sites and is fine with giving herself insulin. The next day before discharge, the registered dietitian visits Margaret and explains about carbohydrate counting. Hint, hint, you might see this again. She tells Margaret to take in 2 to 4 carbohydrates per meal. 2 to 4 carbohydrates per meal are how many grams of carbs? So remember, if you don't know, pause and go back and look and see how many grams is equal to, how many carbohydrates is equal to a gram, and go back and take a look. And you should have C, 30 to 60. Each carb count is approximately 12 to 15 grams. Because Margaret's fetus needs glucose 24/7, she needs to consume 2 snacks a day that are 1 to 2 carbohydrate choices. One of the most difficult times to regulate glucose is after breakfast. So Margaret is told to monitor her glucose 1 hour after breakfast. If it is high, she should decrease her intake by 1 carb and increase protein. Margaret is given a diet history tool so she can record her intake and glucose levels. Margaret is discharged with a return prenatal appointment in 1 week. Another little nice thing to go in is saying, oh, can't seem to find it. Well, that's kind of squirrely. All right. In 1 week, I'll have to look at that. The patient's diet history looks like the following. Circle the meal that requires modification. So take a look, pause, take a look at all those meals, and then I'm going to share the answer with you. So hopefully you circled banana, cereal, milk, and orange juice are all carbohydrates. The primary care practitioner keeps a close watch on Margaret's glucose and provides her with fetal surveillance. At 37 weeks, the estimated fetal weight is approaching 10 pounds. A cesarean birth is scheduled pending an amniocentesis for fetal lung maturity. And I think we did this already.
Okay, for the next minutes, we're going to talk about amniocentesis. That is a procedure in which we are going to collect a sample of amniotic fluid under ultrasound guidance. As I click on the first button, the sound probe comes and insonates the structures. When I press the second button, the sound probe moves in several directions in order to locate the most adequate place for the introduction of the needle. And we're going to understand which one is the safest place. Here, the syringe is introduced through the skin uterus to collect a sample of the amniotic fluid. Here's the fluid. And let's zoom the region to understand the importance of the sound guidance of the procedure. Here we have the sound field. Here we have the tip of the needle, and we can
I'm going to pause and I'll let you watch the rest of that. He does a nice job. I want you to open your textbook, 2 pages, hint, hint, page 508 and 512. You might see this again. Please read about the lecithin sphygmomyelin ratio. And it's also known as the LS ratio. LS ratio. So I don't know if I can use my pointer. Well, yeah, I can. Oh, and darn it. Let me see what's this. Oh, I don't. I'm just going to stop while I'm ahead here. Okay. Anyway, LS ratio. So look at page 508. At 508 on the top of the page under medical management, it tells you lung maturity is determined with the lecithin sphygmomyelin or LS ratio before elective induction or cesarean birth and for women in preterm labor. Okay, so that's telling you what that LS ratio is. So very important. Then if you go to page 512, if you go down about halfway, right above complications of RDS. Now, again, this is in chapter 17, but I want you to know this now. So if you go about halfway down, you see a bullet point and says LS ratio, which is what we just talked about. And then the LS ratio are 2 phospholipids that are detected in the amniotic fluid. And the reason I'm talking about it now is because this is what they're going to be checking for when they're doing the amniocentesis, which we're talking about now. The ratio between these provides information on the level of surfactant. And we talked about surfactant in the production of the lungs, right? An LS ratio, you might see this again, an LS ratio greater than 2:1 in a non-diabetic woman indicates the fetus's lungs are mature. So let me repeat that. An LS ratio greater than 2:1 in a non-diabetic woman indicates the fetus's lungs are mature. An LS ratio of 3:1 in a diabetic mom indicates that the fetus's lungs are mature. So to summarize, the LS ratio is looking at 2 phospholipids that are going to be detected in the amniotic fluid when they do the amniocentesis, when they suspect a mom is in preterm labor, to determine the amount of surfactant present, because we need to determine that, because that is what is going to make sure the baby's lungs are ready to function outside of the outside of the uterus. So in a non-diabetic mom, a normal finding is 2:1. In a diabetic mom, a normal finding is 3:1. All right. The lecithin sphygmomyelin ratio, which indicates fetal lung maturity, is, now the question does not state it, but this is a non-diabetic mom. Otherwise, they would have stated. So what is the normal ratio? We just talked about that. And you should have C 2:1. The fetal tests indicate that Margaret's infant is mature. A C-section is done. The infant is 9 pounds, 13 ounces, is taken to the newborn nursery for assessment. Margaret does well postoperatively and is taken to the postpartum unit. Her glucose levels are checked for the first 2 days and are within normal range. No further insulin or glucose is ordered. The patient asked the nurse if her diabetes will return. The best answer is, go ahead and pause, and I will share the answer with you. And you should have said, D, you are high risk for latent diabetes, meaning diabetes later on in life. The client has just been diagnosed as diabetic. The nurse knows teaching was effective when the client makes which statement? Go ahead and pause. And you should say 4, and I'm going to allow you to pause this if you want to read through the rationales. A newly diagnosed insulin-dependent type 1 diabetic with good blood sugar control is at 20 weeks gestation. She asks the nurse how her diabetes will affect her baby. What would be the best explanation to include? And you should have 2, and then there are your rationales, so feel free to pause. And I'm going to stop saying that. I think you kind of got that by now. You probably think I sound like a broken record. Time for a break. Definitely take a break. I have been giving you a lot of information, so take this time if you have not already and take a nice, good 10-minute break. Welcome back. So hopefully you had a nice little break. We're going to talk about preeclampsia. So I'm going to play this little video.
I'm Sarah Little. I'm one of the maternal fetal medicine physicians here at Brigham and Women's Hospital. So preeclampsia is a disease or disorder that is unique to pregnancy. So we don't know the exact reason why it happens, but we do know that it's somehow related to the placenta. So women who are pregnant who have preeclampsia tend to have high blood pressure, often have protein in their urine, swelling in their legs, arms, and hands, and can have other systems be involved. So can have involvement of their liver or kidney or their blood clotting pathways. In addition, you can look at the baby or the fetus as well to look for signs of preeclampsia. So look at the growth or the size of the baby, as well as the blood flow in the umbilical cord that connects the baby to the placenta. And that can also be markers of preeclampsia. So preeclampsia is one of the more common complications we see in pregnancy. It affects about 5% of women. Some women are at more risk for developing preeclampsia in a pregnancy. So first-time moms have a higher incidence of preeclampsia, as well as older moms, heavier moms, moms carrying twins or triplets, as well as women who have underlying medical disorders. So women with chronic hypertension have an increased risk for preeclampsia, or women with underlying renal disease or kidney dysfunction, or lupus or other autoimmune disorders. In addition, once you have preeclampsia once, you're at higher risk for having it in a future pregnancy. The main complication of preeclampsia is, though, because it's a disorder that's related to the placenta, really the only cure is delivery. So babies often have to be born early when they have preeclampsia, and they can also be affected by the placenta, so they can be small, or the placenta can start to tear off of the uterus early, something called an abruption. So we can see complications from that as well. So at Brigham and Women's Hospital, we see a lot of women who have preeclampsia or risk factors for preeclampsia. Prenatally, we screen women with blood pressure. We ask about symptoms. We'll look at their urine when they're in their prenatal appointments in the office to look for protein in their urine. And then if we're worried that they're developing preeclampsia, we'll often take a closer look at them. Sometimes that involves being admitted to the hospital, to our inpatient service, where we can watch their blood pressures very closely, their babies very closely, collect more information on their labs or their protein level, and try to make the diagnosis of preeclampsia. Mild preeclampsia or preeclampsia without severe features can often be managed expectantly, so you can get more time out of the pregnancy as long as the baby and the mom are doing okay. And even when women have some severe features, so very elevated blood pressures needing blood pressure medications, we'll keep them in the hospital watching very closely and try to get as much time out of the pregnancy that is safe. In addition, studies have found that taking a baby aspirin for women during the pregnancy who have a history of preeclampsia can help reduce their risk of recurrent preeclampsia. So that's sort of one medication we can use to help treat them. And then after the birth, so we work very closely with our maternal fetal medicine, our group and our colleagues, as well as our neonatologists here who care for the babies after the birth. And then women who have preeclampsia in a pregnancy are at increased risk for having cardiovascular complications throughout the course of their life. So we also work very closely with primary care physicians and cardiologists here to make sure that women are getting the care that they need for the rest of their life to keep them healthy. Often here at Brigham and Women's Hospital, we'll see women who had preeclampsia once come even before they get pregnant for a preconception consult to talk about specific risk factors for them and anything they can do for risk reduction prior to pregnancy. So here at Brigham and Women's Hospital, we do have the opportunity to have many specialists be involved and to provide the optimal care for women with preeclampsia. So we have a large team of maternal fetal medicine doctors, both taking care of women in the inpatient and outpatient setting. We have anesthesiologists, and we actually have an OB anesthesia division, so an obstetrical anesthesia division, as well as a large NICU and neonatologists who take care of the babies after the birth. Women who are first diagnosed with preeclampsia, I think it can be very scary, and they're worried about what it means for their health and the health of the baby. I think there are a lot of questions that arise at the beginning, and we try to reassure women, gather as much data, and provide them the best care going forward in terms of prolonging their pregnancy for as long as is safe for them and their baby to really maximize or improve their outcomes for both them and their baby.
All right, so preeclampsia, really important. The diagnosis is made after 20 weeks gestation. You're looking at blood pressure on 2 separate occasions. So a blood pressure of 140 systolically or 90 diastolically, 2 separate occasions, 4 hours apart, on a woman who previously had no blood pressure problems. Proteinuria is not diagnostic anymore in and amongst itself, but they're still looking for anything greater than 300 milligrams per liter in 24 hours. Generalized edema. So pregnant women generally have some pedal edema, ankle edema, especially as the pregnancy goes on. That is okay. What we are concerned about in preeclampsia is generalized puffy face, puffy hands, and the dependent areas, ankles, lower legs, or a new onset systemic disease, I'm sorry, like thrombocytopenia, impaired liver function, any cerebral visual issues. Here's your neuro assessment again: persistent headaches, visual disturbances. So risk factors, I'm not going to read this slide. They did a great job of going over that in the video, but definitely make sure you know that. Assessment findings, again, the blood pressure is our biggest one. And then a complication of preeclampsia is what? What do you think? From your reading, a complication of preeclampsia is HELLP syndrome, HELLP, HELLP syndrome. So you see that elevated liver functions in there. So medical management, so the treatment is delivery. You heard her say that the treatment is delivery. It's an emergency delivery. So we need to make sure that the baby's lungs are developed. So we are going to administer those corticosteroids, hospitalization, antihypertensive drugs. We want to control the blood pressure, prevent seizures. So preeclampsia, there are no seizures. Once those seizures start, it's eclampsia. So once those seizures start, it's eclampsia. Induced birth, I told you about that. And magnesium sulfate is the big drug of choice. And then you also have your antihypertensive medications. Accurate, acute, really good assessment skills. A good assessment skills are going to be the key to your patient's best outcome. And let me repeat that because that goes across all boards. A good assessment skills, good high level critical thinking is going to be the key to excellent patient outcomes. So just my little blurb that I'm going to put out there for people, for nursing students. I hear from students that say nursing is hard. All right, I'm going to say this only once. No, duh. Nursing is extremely hard. It is one of the hardest majors in college. It's hard for a reason. There is a lot to learn. There's a lot to study. It is not for the weak. It is not for those who, lack of better words, are lazy or just want to put in, just enough to get by. I always think that just enough to get by, that is put in, you get out what you put in. And I'm not looking at the grades at the end of a chapter or the end of a module, but how does that knowledge help you at the bedside? And if you're a person who put in just enough to get by, that's going to come out in patient care. And there's nothing worse than having a patient code or crash on you, but a patient code and crashes on you because you didn't detect something, because you don't have high level thinking and really good assessment skills, isn't good. So patient crashing and you're on top of it, you're watching and everything, that's one thing. But anyway, that's just my little blurb there. And I think that's probably why, I mean, I will work with you till the ends of the earth to help you understand and be successful. But I am strict, and it's for that reason. I want to make sure that when you graduate, you know what the heck you're doing. So anyway, so this is an absolute medical emergency, preeclampsia. So accurate assessment, blood pressure monitoring. Remember what we talked about. Assess for CNS changes, headache, visual changes, changes in deep tendon reflexes. Your book goes over on box 7.3 and figure 7.9. It goes over that. Have a really good really assess those lungs, monitor for any signs and symptoms of pulmonary edema. So if you're listening and you're going to be, listening for any crackles, any changes in behavior, epigastric pain, generally the right upper quadrant. You're going to be doing daily weights and checking those urine for protein. Hospital care of eclampsia, monitor DTRs, seizure treatment. Think back to what you learned about seizure management. So we want to time it. When did it happen? How long did it last? We want to be monitoring that baby, signs of any placental abruption. Airway needs to be maintained. Side positioning, suctioning, padded railings, and monitoring and running mag sulfate. Fetal risks to preeclampsia, so that baby is not getting the oxygen. So they're having placental insufficiency. The babies will be born preterm. They will be small for gestational age. They'll be having fetal hypoxia. They're having trouble with getting oxygen. High levels of magnesium during the seizure. The baby's heart rate will drop. They may have transient late decelerations, which we will be talking about later. Decreased variability, we're going to be talking about later, and compensatory tachycardia, because their body's trying to stabilize. And this may necessitate an emergency C-section. Please go through this deep tendon reflex exam. I'm not going to play this video for you, but please go through this and watch this and really pay attention. If you, it's been a while since you've had neuro, I would revisit this. And I just have here the steps to do a good deep tendon reflex and checking for clonus. So you want to refresh your memory on your grading of your reflexes. So we want to have a +2 response. A +4 response is your seizure activity. Very brisk, jerky, clonic is your +4. No response, you see that with mag toxicity. And in no response, you're not seeing, your respirations are going to be tanking. So normal reflexes are 1 to 2. And we want to watch for high and low levels of magnesium, and hyperreflexia may be present, and with high magnesium levels, and reflexes may be diminished or not present. I told you that an example, or not an example, a complication of preeclampsia is HELP syndrome. So the abbreviation for HELP syndrome, and you might see this again, is hemolysis for the H, elevated liver enzymes. So go back and know your liver enzymes, low platelets, go back and know your low platelets. It poses a risk of abruptio placenta, renal failure, and liver hematoma. And management is delivery. Placental abnormalities and hemorrhagic complications. The next four we're going to talk about is placenta previa, abruptia, accreta, and ectopic. So placenta previa is the placenta is improperly implanted into the lower uterine segment. And a lot of these complications are a C-section delivery only, especially if it's a complete placenta previa. So if you see, that's the lower. So if you see the placenta is on the lower left-hand side, it's partially covering the cervical os. So this would not be a vaginal delivery. And what also would be contraindicated? Doing a vaginal exam, correct. And then especially in a total placenta previa. There's some signs and symptoms of placenta previa and abruptio placenta. And I just want I want to bring your attention to a couple of important points here. So in abruptio placenta, it's insidious and it happens very quickly. And you're going to see very dark blood, abdominal pain, and it happens very, very quickly. In placenta previa, you may see trickling of blood. It's a slower onset. And with abruptio placenta, you may see preeclampsia. So the bleeding, the onset, and the pain in abruptio placenta, it's severe, constant, dark red blood. So clinical therapy is bed rest, no vaginal examinations. Like I told you, you're going to be checking their H&H. They're probably going to get blood and any blood products. Evaluate the baby, very key. Monitor vital signs. Get a set of labs. You want to type and cross. And administer that betamethasone to facilitate fetal lung maturity. Abruptio placenta, so basically it's a premature separation of a normally implanted placenta from the uterine wall. Marginal, there's a marginal, so you see that very dark, frank blood. Central and complete. Again, clinical therapy, coagulation, type and cross, transfuse blood, emergency C-section, monitor baby, maintain cardiovascular status. The next thing we're going to talk about is your TORCH, T-O-R-C-H, TORCH infections, and it's an acronym that stands for toxoplasmosis, others such as syphilis, rubella, cytomegalovirus, and herpes. And these all have potentially devastating effects on the fetus. Remember, we talked about infections before. One of the other things with infections is it brings on preterm labor. Your text has a lot of medical management depending on the organism and the trimester. So go back to table 7.5. GBS positive. I want to spend some time talking about GBS positive. So this is another one that I was talking about in your CLGs where I want you to be able to know when they're testing this. So it's generally between 35 and 37 weeks gestation. It's colonized in the genital and rectum. And it's normal bacteria that is present that it basically gets out of control, and it causes preterm labor, and it also causes sepsis. Sepsis causes respiratory distress, hypoglycemia, and issues with thermoregulation. So it causes a lot of issues. Mom is checked, and she needs 2 doses of antibiotics prior to delivery is the protocol. If mom has not had any prenatal care, then it is assumed, and I know we shouldn't normally assume because it makes a out of you and me, but we're going to assume that mom has GBS positive and we're going to treat prophylactically. DVTs. So DVTs, moms are at high risk for DVTs. It's increased in pregnancy. So make sure you know your signs and symptoms of a DVT and how do we treat it. So we're going to treat it with heparin, right? So warmth, pain, swelling. Remember that that positive Homan sign is kind of, is the literature's been kind of throwing that out. Worst case scenario, PE. So make sure you know what DVTs are, what are the signs and symptoms, how we're treating them. Next week's lecture is chapter 5, module 1, PowerPoint 3. We'll talk a little bit more about groups. We will have, ignore those dates. I just realized your exam is not September 24th and 25th. It is, so next week, Morgan will have the same nurse present. The other classes, they will most likely be recorded. And then your exam will be February 16th and or February 17th. Morgan will be Tuesday, February 16th, 9:30 to 12:30. And main days will be February 17th, 9:30 to 12:30. And online and PM will be February 17th, 4 to 7 p.m. And that is it. Thank you for listening, and please post any questions in the Q&A.